RA or rheumatoid arthritis. Today we will cover about the diagnosis of rheumatoid arthritis. The treatment part will be covered in the next video. Now the diagnosis of rheumatoid is basically a clinical diagnosis, and what we use as a diagnosis are the ACR or the EULAR criteria. These are not actually diagnostic criteria, these are basically a classification criteria, but they guide your diagnosis. Now they were originally given in 1957 and later modified in 1987. These criteria were later modified in 2010, and what changes were introduced were number one, the morning stiffness criteria was reduced from 1 hour to 30 minutes. Now 30 minutes of morning stiffness is considered significant or included in this criteria. So second was the radiological criteria was removed, so that in the current classification criteria there are no x-rays to be done, and you can still diagnose your patient as rheumatoid. Thirdly, what they did was the introduction of acute phase reactants like ESR and CRP were introduced as a major classification criteria. So today also we follow the criteria given in 2010. Now let's study these criteria according to the official website of EULAR. This has been given in their official website, and you can also check them out yourself online. Now what they say is that you have to use this criteria in a target population. What is the target population of this criteria? Number one, the patient should have at least one joint with definite clinical synovitis. At least one joint with definite clinical synovitis, like which is the swelling. Number two, this synovitis should not be better explained by any other disease. So these two criteria must be met for a patient in whom we are going to apply these criteria. Next is the components of the EULAR criteria. There are 4 components: joint distribution, serology, symptom duration, and acute phase reactants. Now let's study each one by one. Firstly, it is the joint distribution criteria. It has 5 headings, and it starts with involvement of one large joint, then about 2 to 10 large joints, which is given point 1, and 1 to 3 small joints. When the large joints are not being counted, it is given as 2. If the joint count is more than 4, small joint count more than 4, then it is given 3. And if more than 10 joints are involved, including at least one small joint, then it is given a 5 points. Now you can remember these criteria easily, but what is the catch here? The catch here is that the importance of small joint involvement is more than the large joint involvement. So the large joints are given lower scores. So the scoring will start with the large joint. So if a patient with one single large joint is involved, it is given 0 score. Then if the large joints are involved up to 10 in number, it's given 1 score. Now we come on to the small joint involvement. If less than 3, which is known as your polyarthritis involvement, it is given 2. Then if more than 3, it is given 3. And if total joint count is more than 10, including one small joint, it is given 5. So clinically, how you can remember is, if a patient comes with bilateral MCP and PIP joint involvement in both the hands, it automatically sets the criteria to 5, because more than 10 joints are involved, and these are the most common joints involved in a rheumatoid arthritis patient. So if a patient comes with the swelling of bilateral MCP and PIP joints, automatically the joint distribution criteria comes out to be 5. Next criteria is your serology. Now serology is a very simple subject. What is here? It is 2 serologies are considered: rheumatoid factor, and secondly anti-CCP antibody. These 2 tests are to be done in every patient, and it is given a score of 2. The starting score is 2, not 1. Okay, remember this. 2 is given when the serology is positive, but it is a low positive. When do we see a low positive? When the titers are less than the 3 times of the upper limit. If they are less than 3 times, it is given as a low positive value. Sometimes you don't have the quantitative test available, so in that case you are given only the qualitative value, that is your plus or minus. In that case, When your quantitative value is not available, then you have to take the qualitative value as a automatically as a low score, not as a high score. If it is high positive value, that is meaning thereby more than 3 times the upper limit, it is given a score of 3. Next criteria is your symptom duration. It is simple. If it is more, it is significant. If it is more than 6 weeks. Next criteria is your acute phase reactants. Acute phase reactants. Two acute phase reactants are tested: ESR and CRP. Okay, different labs have different values for each, but usually ESR is positive if it is more than 20, and CRP is positive if it is more than 5. But different labs have different values. So what we have to do now, we let's revise these criteria. 4 criteria are given: 1, 2, 3, 4, and scoring for each one is given. You have to add these scores by simple addition, and you have to label a patient as a definitive rheumatoid arthritis patient if the score is either equal to 6 or more than 6. If the score is less than 6, patient might fulfill these criteria over a period of time. So sometimes you diagnose these diseases later on also, and sometimes if currently he or she is having a score of less than 6, but retrospectively the reports show that sometime in the past he or she has achieved the score, then also we have to label this patient as a rheumatoid arthritis patient. Now a word of caution that this is a classification criteria, not a diagnostic criteria. We have not developed diagnostic criteria yet, but typically in a rheumatoid disease, criteria is labeled as a classification criteria, and they are helpful in defining the homogeneous treatment of populations for study purposes. And a clinical diagnosis has to be established by a physician. Okay, now these are simple things, not very important. And a point about the radiology. Initially, the 1987 criteria used to give criteria of radiology also, but now they have been excluded from the current 2010 criteria, and radiology is not to be performed until unless it is necessary. Now some definitions. We have studied about the criteria. Now let's study about the definition of each one. Now the joint distribution is said to be a joint involvement when there is a swollen or tender joint. Now which joints are excluded from this counting? Your DIPs which are usually affected in osteoarthritis. Secondly, your first MTP joint, which is the most common joint involved in your gout, and your first CMC joint, which is also the most common OA of small joint. So these 3 joints are excluded in this joint count. Now joint involvement is usually your clinical criteria, but sometimes additional evidence may be gathered from an MRI or USG. Okay, so this was about the joint distribution. Now second is your about serology, and about the definition of a small joint. Small joints are excluding these 3 joints like we just studied, like you're excluding your DIP, first CMC and first MTP. All other joints are small joints, which you already know. But the catch here is your wrist joint. Now some of you might confuse it with a large joint, but in these EULAR criteria, wrist joint has been included in a small joint. This is important because small joints are given more value in this criteria. Large joints are given less points. So your wrist is a small joint. Next is large joint. Your simple large joints are the shoulder, elbow, hip, knee and ankles. Again, to be stressed, your wrist is a small joint. Next is your, when will you say more than 10 joints involvement? Whenever you say more than 10 joint involvement which leads to a score of 5, it should contain at least 1 small joint involvement. And some additional joints which can also be included in this counting are your TM joint, your sternoclavicular joint, your acromioclavicular joints, okay, and some other joints not exactly mentioned. Next definition is your about serology. Like we just studied that negative is your less than upper limit. A low positive is when it is less than 3, the upper limit, and high positive when it crosses more than 3 times the value. Next is your definition of symptom duration. It refers to the patient's self-report on the maximum duration of signs and symptoms of any joint that is clinically involved at the time of assessment. Points to be noted here are the patient's self-report, not your clinical assessment. If the patient is reporting that he or she is having symptoms in the last 6 weeks, it is significant and given a point of 1, a score of 1. Next is your algorithm. This is very simple, you can study it later. Now we can do some examples also. Now this example number 1, let's assume that a patient is having more than 10 joints involvement. So he or she gets a score of 5 instantaneously. Okay, assuming that at least one small joint is involved. Now we do a lab test on this patient. The serology comes out to be, if it is negative, then we look on the duration. If the duration is also less than 6 weeks, no score for that. Then we come on to the acute phase reactants. If it is still negative, still no points, and we exclude this patient as not having RA. However, if such a patient comes with any of this criteria, any of the other 3 criteria is fulfilled, like even if serology is negative and the rest of 2 are negative, still it will have, patient will be of RA. Similarly for other 2 criteria also. Now what we come to next is a false positive classification. Sometimes we will see that the patient is able to fulfill all the criteria, leading us to a score of 6, but this is a false positive. They have, the EULAR people have themselves mentioned that a false positive may be concluded with this classification criteria. Which example they have taken is, if a patient comes to you with a small more than 10 joint count involvement, including one small joint, given a score of 5, the serology is negative and the acute phase reactants are negative, but the symptom duration is your more than 6 weeks. Now the score will come out to be 6, and according to this criteria, it will patient will be labeled as RA, but this is a false positive condition, and you have to look for other causes of the synovitis or joint involvement of the symptoms, and not given as a false positive. Now sometimes a patient may also have a false negative classification. In this case, the patient is your the example taken in this scenario is a patient presenting early to you. If a patient is presenting early and has a lesser joint count, less than 5, let's assume a score of 3, and a serology comes out to be negative, no score here, and the patient is presenting early to you, so the duration is less than 6 weeks, and somehow the acute phase reactants are positive due to the acute exacerbation of the disease, still the score will come out to be, the addition of the score will come out to be 4, and patient will not be able to fulfill your score of 6, and you might not be able to diagnose this patient at the first visit. So a next visit is necessary in order to prospectively classify this patient as a rheumatoid or exclude, depending on how the disease progresses over time. Some important footnotes here are that the classification criteria are your classification criteria, not diagnostic, we have already seen, and radiographs should not be obtained in this new criteria, only in some cases. And there is a drawback of this classification, that there is no exhaustive list of exclusions defined by this criteria. Now, so in summary, they have also given summary. In summary, that we have new classification criteria for RA given in 2010, and the criteria are meant for patients with clinical synovitis in at least one joint, which is your target population. And these are not diagnostic criteria, but they can inform the diagnosis, which is good enough. All as clinical practitioners, we use this criteria in our OPDs to diagnose a patient of RA. So you can also reliably use them, either you are an orthopedician or you are a rheumatologist. Now some other studies are also going on. So this is all about it, and we will study about the treatment part in the next video. Thank you.